Hi, everybody. Just want to get some lectures up and recorded for emergent conditions. Um, the other part is related to bites. And then actually, I know it sounds kind of funny because they don't all coincide together, but the other one is lupus too. I just wanted to cover that real quick. Um, Sorry for the delay. I had two DMP students, two doctorate students that I'm cheering. Um, and they were just finishing up and graduating. So I had to get them finalized and then that moving along. So I've been busy the past day or two trying to finish that up. Okay, so this is the PowerPoint for emergent clinical presentations. I'll try to go through it somewhat quick. Let me move this because otherwise I can't see good. And then, because I know a lot of this is kind of straightforward and a lot of it has the same principles involved. So the first part I want to talk about is in terms of bites, cat bites, dog bites. Those they're super common, and you're going to see it a lot in clinical practice if you haven't already. I know if you work in the ER, you tend to see a lot of this, or if you've ever been in urgent care, I'm sure you've seen it already. And they do tend to test on boards in regards to bites, like the management of it and the bacteria. So make sure you know the bacteria, for cats and dogs, which they're very similar. They're both Pasteurella. And then like the management in terms of antibiotic therapy and like tetanus prophylaxis. Cat bites can become really bad very quick, like in a matter of hours. So they can have, serious implications, a serious infection after. And really, it's because their teeth are so sharp, they basically are injecting like bacteria deep into the tissue. So it's like injecting it almost right into the deep tissue space, and then a develop or an infection will develop essentially. And it's obviously very common for them to carry bacteria in their mouth, just like a human bite, but it's even worse. Um, so if you have a cat bite and dog bite, especially cats definitely get worse than dogs do, but put them on antibiotics. You have to make sure that they're covered. So the history, you want to make sure, obviously, you're doing a good history, like the circumstance of the bite. Was it a stray cat, dog, or was that a house pet? Because you want to know whether that cat potentially or dog could have rabies or another infection. Obviously, too, if it's a house cat, it's a little bit different. You're not so concerned about that because typically they're vaccinated. So you do want to inquire about the vaccine status of that pet or cat, and whether it's a stray. The other big thing too is think about your patient's medical history. Obviously, if they're immunocompromised, things like diabetes, significant CAD, um, like those any history that can predispose them to that immunocompromised state, you want to make sure you're very aggressive with management and follow up as well. The other thing is always, and I know I mentioned this before, any patient, you should always um, inquire about allergies, allergens to antibiotic therapy specifically, because it's probably the number one cause of drug allergies, which is antibiotics, most commonly penicillin. Penicillin is probably the most common allergen. You have to make sure that your patient knows their tetanus vaccine history. So you can always look that up in MICR. If they're unsure, then you want to make sure that you vaccinate them, or if you can't find out the status of it, you want to go ahead and vaccinate them. You're better off, you're safer of vaccinating against tetanus than not. So look up the status, and then I believe if it's in within 5 years, if it's past 5 years, you want to give them an updated booster. And then if they're under that 5 year window, they're okay. But make sure you inquire about that. So good history and physical obviously is critical too. Make sure you look at that puncture wound, make sure that there's no foreign bodies detected. Any type of wound, you want to make sure there's nothing, located inside that wound. So look with a good lamp or a pen light to really inspect it. Check for erythema, any drainage, warmth. Most patients tend to present pretty quickly with cat bites, but obviously, like I said, they can progress really quick. Look at this, the area of infection. If they do already I can't talk today. It's been a long day already. If they show signs of infection, it's always good to kind of outline it in a marker so that they can look at the outline of where that wound is or the infection spread. And it gives the patient a good gauge too to make sure that it's not spreading outside that line of demarcation that you put around it. And then it's also good for follow-up. So that if you're having a come back in a day or two just to reevaluate, you can see where that line was and whether it's resolving, the erythema or swelling is resolving, or if it's actually getting bigger. You really want to palpate and look at the other for any joint involvement or tendon involvement, obviously, because cat bites, they do have the potential to go deeper within the tissue space and can cause septic arthritis or arthritis in the tendons or the tendon sheath, essentially. So you want to do a look for that as well. As I mentioned, they have a very, very high risk of infection, up to 50%. So a cat bite, you're going to be putting them on antibiotics. And like I said before, make sure you know the bacteria. For cats, it's Pasteurella multisida. There are other bacteria, but what we put them on will cover all of it, and it targets Pasteurella. Watch for rapid progression of symptoms. So you want to make sure you're educating them on when to go to the ED for systemic therapy or IV therapy, antibiotics, and all that. Um, so those signs and symptoms of infection, like progressive pain, severe warmth or redness, or if they have systemic fever, fatigue, body aches, things like that. So they need to be followed up with very quickly. So in terms of management of that wound, the big thing with bites is you don't want to necessarily suture them closed or steri-strip them closed. You want to make sure that you're actually cleaning it out really thoroughly with just plain old soap and water. You can also, after doing that, use like a saline irrigation. So you want to spray it out with saline. That will help you look for any debris in there as well and remove any of that debris. And it actually reduces that bacterial load as well. So like again, you don't want to try to close them unless it's cosmetically necessary. So typically we leave them open, but with cat bites, it's usually not that big of an issue. In terms of antibiotics, Augmentin is the first line treatment. Alternatives for penicillin allergic patients would be like a Doxy or Bactrim. But you also have to combine it with metronidazole or clindamycin to get full coverage. So first line is amoxicillin with clavulanate if they're not penicillin allergic. And then if they're penicillin allergic, it's Doxy or Bactrim with Flagyl and clindamycin or clindamycin. Um, Typical course is 5 to 7 days for prophylaxis or longer for established infections. So definitely for cat bites, I would automatically just write them for the 7 days. If they already have established infection, you want to make sure that you're writing it for probably 10 days in the patient. And then ensuring that they follow up with you within like 2 to 3 days to reevaluate the infection, essentially, make sure that it's not getting more severe. Tetanus vaccine, like I already mentioned, you want to make sure that's up to date and administer. Rabies consideration, I already kind of mentioned this. If you have to really assess the risk there based on the cat's vaccine status and their behavior. So you want to inquire about the cat's behavior as well. You can quarantine, observe that cat if it's domestic for 10 days. If rabies is suspected, there is PEP or post-exposure prophylaxis if the cat's not available or if they exhibit signs of rabies. So that's if the cat is like a stray cat. And then usually obviously refer to the ED for management. You always want to reassess within 24 to 48 hours for signs of infection or worsening symptoms. And then obviously the educational piece, like I already mentioned. You absolutely need to refer to a specialist, whether it's infectious disease or ortho, if there's any complications that arise, like they may have an abscess formation, deep tissue involvement, where they have palpated tenderness over a joint, or any signs of systemic infection. You want to make sure you get them sent out as well. So then that's where you refer to specialty here. In terms of dog bites, very common as well, and they can be minor abrasions to more severe trauma. They do carry the risk of infection, and obviously you need to evaluate and treat appropriately um, within an appropriate time frame. So same type of thing with the history. Is the patient immunocompromised? What meds are they on? What's their past medical history? Then the history of the dog, whether it's a pet or a stray, looking at their vaccine status, all those factors as well. Circumstances of the bite, whether it's provoked or unprovoked during play, essentially. Canine health, look at the vaccine status of the canine, and then obviously ownership status, and then the patient's immunization histories, specifically for tetanus. Risk factors for infection are the same ones that I kind of mentioned before. So if they have a delayed presentation and they aren't coming in for a few days or up to a week, they're obviously at high risk for infection because they have not been treated. Same type of thing, examine that wound, look for signs and symptoms of infection, look at the depth, look for involvement of any joints or tendons or neurovascular structures. Excuse me. Make sure you check the neurovascular status distal to the bite, essentially, and do this for both cat. Anybody you should be doing this for as well. So in terms of infections, again, it's very common. It's Pasteurella, but it's Pasteurella canis instead of multicida, which you see with cats. There are different organisms like staph and strep that can obviously cause infection as well. So once again, those meds that we put them on, the antibiotics, cover all of these. And you have to make sure you're providing good gram-negative and positive coverage. There's less common bacteria as well, but it's more, but it's very concerning, obviously, in immunocompromised patients. Risk factors for infection, obviously those deep puncture wounds, delayed presentation, which is considered greater than 12 hours, bites on the hands, face, or feet. And a lot of too, like when you think about the hands and the feet, it's, think of it too from a circulatory perspective, like the circulation to your feet and hands and those immune fighting cells essentially your perfusion to that area isn't as good as it is when it's more central on the body, essentially. So that's another reason why they have high risk of infection. Again, wash it very thoroughly with soap and water, irrigate with sterile saline to remove debris and reduce bacterial load. If it's a tissue, like they're already starting to get tissue necrosis or they have a lot of slough on top, essentially you can remove some of that tissue if necessary, but I would do it through like more of an irrigation if you can, because you don't want to cause any debridement of the healthy tissue as well. Again, leave those wounds open to heal by secondary intention, especially in high risk areas like the hands or the feet. You really only consider primary closure, meaning sutures or steri strips, when it's like a facial wound or a large clean wound in a cosmetically sensitive area. So again, you leave them open. Antibiotic therapy is the same. So again, you're using augmentin, amoxicillin clavulanate for 5 to 7 days for prophylaxis, 7 to 14 days for infection. I know I said 7 to 10 for the cat, but honestly, if you're better off being safe and going towards the longer spectrum in terms of treatment with these patients. Again, if they have an allergy, you go to like clindamycin with Bactrim or clindamycin with Doxy. Any indications for antibiotics, like if they have a deep puncture wound, if it's a hand or foot injury, automatically you're going to put them on it if they're immunocompromised. So if they're on certain meds, or a disease state that makes them compromised, or if they have delayed treatment in terms of like cleaning the wound out, you obviously want to get them started on antibiotics as well. Tetanus prophylaxis, once again, same thing. Look at the immune status of the patient. If they're unvaccinated and the wound is very dirty, there are immune globulin prophylaxis that you can do as well. Again, rabies considerations, look at the dog's status. If the dog's vaccinated and healthy, observe it for 10 days. If it's stray, you really should consult with public health authorities to initiate prophylactic post-exposure therapy, essentially. You always want to have these patients come back within 24 to 48 hours just to look for signs of infection or how their healing is going. Again, educate on those signs and symptoms of progressive infection, essentially. Refer again if there's any further damage noted, or even the other thing you have to think about too with dogs, especially bigger dogs, is fractures. It can actually cause like a crush injury to that bone, so there can be issues with that as well. So another thing you kind of got to think about with large dog bites. So again, just make sure you know the antibiotics, the bacteria, and that you really you typically leave them open, and then tetanus prophylaxis as well, looking at that. In terms of poisoning, it really depends on the substance. And if you work in the ED, I'm sure you probably have seen this, or even if you've been in the urgent care, you might have seen some of this. The ones I see in primary care are typically more related to exposures like cleaners or pesticides is another big one I've seen. And it really depends on the type of substance that they're exposed to in terms of the presentation that they have. So obviously, when you take a good history in a patient, you always want to look at exposures, whether it's exposures to ill people, exposures or changes in their environment, or exposures to potentially toxic substances. So you always inquire about that within the patient's history, because sometimes they'll present with these weird, vague symptoms, and you really can't tie it back to something. So you always want to look at exposures. Um, so again, it depends on the substance, and if you know or you can identify the substance, you obviously want to make sure that you're contacting the Poison Control Center for treatment guidance, because obviously the treatment depends on the mechanism of ingestion and the actual chemical ingested, essentially. So look at your patient's occupation, because look at if you look, they may be working in the field, like with pesticides. If they're military, things like that, you always want to look at it as well. Taking the wrong meds can actually happen too. Taking another family member's medications on accident, not knowing that. Sometimes they can even present with like an allergy, or obviously there's intentional medication overdose or illicit drugs, which I'm sure you guys are all pretty well aware of by working in the hospital setting. Let me go back a few more things. So just make sure that you know that you obviously contact poison control for treatment guidance, and then it should be treated in the ED anyway. So these patients should really be, if sent to the ED. I know some of them present to the urgent care setting, but if you're suspicious of poisoning, then they obviously need to be sent. And sometimes EMS needs to be called to transport them as well. I know at the beginning we talked a little bit about like allergies, allergic rhinitis, but during this module, I wanted to make sure I touched on anaphylaxis a little bit more because it's critical, obviously, across the lifespan, whether it's little kids, pregnancy, older adult, anaphylaxis can affect everybody. So that's why once again, you take a good history. Always look for the history of allergies, whether it's medications, food allergies, and seasonal allergies. So I always try to go into all of those, um, or do they have like a contact allergy, like to latex, things like that too. But the common triggers you'll see here are listed, whether it's foods. Peanuts obviously are a huge one. Tree nuts are one. Sometimes you can be allergic to peanuts and not tree nuts, or both. Shellfish are a huge one. Eggs are a big one too. Some kids tend to outgrow egg allergies as they get a little bit older. And even with the other ones, sometimes they outgrow them where they become more sensitized to the allergen and they're not as severely as allergic. Medications, big ones, like I already mentioned, are antibiotics. NSAIDs are another big one, like ibuprofen or Advil is one that you'll see commonly patients being allergic to, or different anesthetics. Whenever you're inquiring about this within your history, which I'm sure you remember from assessment, you always inquire about what happens. So what is the response to that allergen? Do they get a rash? Do they get a stuffy nose? Or do they get full-blown anaphylaxis or symptoms of those anaphylactic reactions, essentially? The other thing, obviously, are insects. I'm sure you've seen this before too with bees and wasps. A lot of patients are allergic to bees as well. Remember from patho too, it takes that like secondary exposure. So the first primary exposure to the allergen, and then you develop the IgE mediated response, and you develop antibodies to it. And then it's that second, third, fourth exposure to the allergen, and then they have more severe reactions as time goes on. So that's critical to relate to your patients that these allergies may unfortunately become more severe if they have continuous exposure to them over time. So education with anaphylaxis management or prevention is key. It's critical. In fact, the highest mortality rate is actually in college age students because they become independent, they're off on their own, but yet they don't really remember, or they or they just don't bring it with them. Like I think they just forget because they're on their own now. They don't have their EpiPens. They don't know how to respond appropriately or when to go to the ED. So making sure that you're educating everybody, whether it's kids, parents, um, obviously the patient, it themselves in terms of what to do, and having an anaphylaxis management plan like you would with an asthma action plan. There are other triggers of anaphylaxis, like latex can cause it. There's exercise-induced anaphylactic reactions, or even idiopathic causes. So I even had a patient that had cold urticaria. They didn't necessarily have anaphylaxis, but they would get, with exposure to cold, whether it was outside or cold water, they would get hives from it. So there are other triggers too, in regards to just besides like food and meds and bees. So you really kind of got to delve into what they're allergic to, and it may be multiple different allergens essentially. So you always want to record that plus what the reaction is to it. Obviously, you can read the symptoms, and I'm pretty sure you know the symptoms of anaphylaxis at this point. But the big thing to recognize is that they can have not only just like the skin, like hives or angioedema and the respiratory symptoms, but there's patients that also present with GI symptoms, like severe nausea and vomiting, severe diarrhea that comes on like quick, like real quick with abdominal pain. And they usually have hypotension with it due to that fluid shift. And you can get hypotension with any of these reactions because of the fluid shift. But they may even have like neurologic symptoms like confusion, anxiety, or that sense of impending doom. So it's not just respiratory and skin that you may see, but you may also see GI side effects with it as well. These patients that obviously have an anaphylactic reaction or symptoms of an anaphylactic reaction obviously need to be managed or evaluated at least by an allergen, because they need to go through thorough allergy testing to look at what exactly they're allergic to rule out potential allergens, and so that the patient knows what to avoid. So diagnosis is most likely when you have like that acute onset with skin or mucosal symptoms, and respiratory compromise, and then typically hypotension because of that fluid shift. Typically, you'll see two or more systems involved, and then they tend to have hypotension with it. Obviously, the biggest thing is ABCs, transport to ED. First line treatment is instructing that patient that they need to go to ED, even though their symptoms resolved with epi, because their first line treatment obviously is epinephrine, and EpiPen, and making sure, number one, make sure your patients have enough EpiPens, that they have one at home, they have one in their car, backpack, etc. Usually you can write for 2 to 3 at a time. That way they have them and they can put them in multiple areas in case they were to leave their home and they forget. So it's instructing them to make sure that they're actually carrying an EpiPen with them at all times. They have to have it with them. So that's critical to relay to them. The other critical factor, like I said, if they use an EpiPen, they still need to go to the ED because they can have a biphasic reaction where they actually have a secondary allergic response that can occur anywhere from an hour after up to 3 days after. And usually, obviously, when they go to the ED, they'll get them stabilized with fluids. And then we get patients put on like steroids and all that too, which actually will help prevent that biphasic reaction from happening. Sometimes, obviously, a second dose in epi is needed as well. And they can repeat that every 5 to 15 minutes based on the response. It's the only life-saving treatment and it delays mortality risk. So they absolutely should be using it. Some patients are afraid to use it or um, or families are afraid to use it, but you got to relate to them that they absolutely need to use it. Because sometimes the wait and waiting is not obviously a good idea. So you want to make sure that they know when to use it, how to use it. And you can even have them bring in the EpiPen just to have them go through the whole process of using the EpiPen and where to administer it, and then a plan of what to do. And that's why it's good to do an action plan, like an asthma action plan, because it gives them something handwritten that they go home with, and it's a good reminder that of the steps that they need to take. Other therapies, mm, these are not a cure, but obviously, again, it's only for symptomatic relief. Like Benadryl is obviously always given. If you don't have IV or IM, obviously it's quicker acting because of the route. You give them oral, 50 milligrams, and then obviously you can repeat it again. The other thing that can be given is H2 blockers like Pepcid or Zantac. So they work on histamine. Um, and they also work with like H1 blockers, like an antihistamine, but it targets H2 and kind of hits H1 a little bit as well. So sometimes we'll put them on Zantac or Pepcid with it as well. Steroids, so methylprednisone or hydrocortisone to prevent that biphasic reaction, because they have that delayed effect and they get like a secondary peak with the allergen response. Obviously, bronchodilators like albuterol, nebulized formula, you can do that in the office, urgent care setting, or even obviously in the ED. Um, and these patients obviously need to be sent to the ED if they're having difficulty breathing as well. And they need to be sent even if you use your EpiPen. So post-episode management is making sure that these patients know that they need to avoid triggers, and we need to figure out what the triggers are. So sometimes you'll see a patient after a post-hospital stay, follow up, and they're seeing you, and they don't really know where to go after that because they were just treated in the hospital. So it's your job to make sure that you have the care coordinated and that they have the proper tools on hand and what to do in terms of an acute episodic anaphylactic reaction, essentially. So it's education, treating or teaching them how to use the EpiPen, making sure that they have prescriptions and enough EpiPens to have with them in multiple locations. And I already mentioned college students they have the highest mortality rate. So ensuring that you're educating them and their family members as well in regards to this. They do need further testing via an allergist and then obviously develop an action plan. You can find those online. They're pretty much everywhere. And I know even like the guideline book has access to an action plan that you can use for patients as well. In terms of allergies, you can have allergies obviously without having a severe anaphylactic reaction. And I'm sure y'all know this, but you can have like very diverse symptoms that include anything from rhinitis to eczema to urticaria to bronchospasm to anaphylaxis. So you can go anywhere along that spectrum. And remember before, I think I've told you this numerous times, but like those patients that have asthma are at higher risk for eczema and allergies. If you have allergies, you're at higher risk for I'm blanking out. If you have allergies, you're at higher risk for asthma, vice versa. So obviously, again, outdoor allergens like those seasonal ones, those are very common. Indoor allergens like dust mites, indoor molds, animal dander, those are more the ones that cause like urticaria, rhinitis, or worsening asthma symptoms. They don't necessarily always cause anaphylaxis, but they're troublesome to the patient. 90% of all allergic reactions occur from the ingestion of 8 foods. So these are cow's milk, hen's eggs, peanuts, tree nuts, fish, shellfish, soy, and wheat. So that's 90% of them. Now, the other thing too is making sure, like differentiating between like a sensitivity and actual allergy. So like an IgE allergy is different than a sensitivity. So you may have some patients that are sensitive to milk or lactose intolerant, but not necessarily allergic to milk. So you can do different testing, whether it's sending them to an allergist and having them doing pinprick tests, or there are blood work um, or serum testing that you can do as well for IgE um, allergies as well. Okay. So obviously, in terms of food allergy management, it's kind of the same thing like I mentioned before with anaphylaxis. You have to identify those triggers, look at the timing of it. When does it happen? What symptoms do they have? That urticaria? Do they have swelling of the lips or the mouth, shortness of breath? Do they have any GI symptoms, or do they have like overt anaphylactic symptoms as well? So diagnostic testing, you can do like the serum IgE levels to confirm allergen sensitivity, but like it's not necessarily 100% diagnostic. So that's why we tend to send them out to an allergen or an allergist to do more skin prick testing, and that's more to confirm it. Um, Oral food challenges, these are done under medical supervision, but it is technically the gold standard. They're not done that often, to be honest, because you're predisposing the patient to having a reaction. Um, but it's really the gold standard mechanism in terms of diagnosing it. But a lot of times, obviously, we do like skin prick testing through an allergist, essentially. Again, I already talked about this avoidance of food allergens. The other thing too is making sure that you're educating them about cross-contamination and food prep. So eating out at restaurants is a big thing. Some patients can't even be in the same room with an allergen. Like younger kids, the same type of thing. Like if they're at lunch, where are they sitting? Is it in the classroom? Things like that. So you have to kind of go through all of that. And you will touch on this more once you get to pediatrics. If you're in peds or if you're FMP, you'll talk about this more too in regards to severe allergies in the pediatric patient and even mild allergies. For mild symptoms, like let's say they just have a rash or pruritus where they get hives and they don't have symptoms of anaphylaxis or anything like that, then we use oral antihistamines. Those first generation ones are more effective. So the first generation ones are like diphenhydramine. They work a lot quicker and they're much more effective for hives. You can use other ones like Claritin, Zyrtec, Allegra, the longer acting antihistamines, which are non-sedating. You can also use those as well. But if you have a more troublesome reaction, you obviously definitely want to go with that diphenhydramine because it's quicker acting and it's much more effective. For severe reactions, obviously that's when you're moving to like epi, and then they're going over for care at the emergency room. Again, I already mentioned this. Anaphylaxis, obviously, they need physician consultation, ED management. Um, in terms of anaphylaxis, it's the same thing with bites or stings. People are allergic to fire ants, sometimes allergic to wasps, sometimes allergic to bees or multiple different types of bugs. Even mosquitoes, you can see people be allergic to. I actually know somebody that gets anaphylaxis. It's more the GI symptoms from mosquitoes. So it's actually terrible because when you live in Michigan, it's very difficult to not get bit. Um, Cases of black widow or brown recluse spider bites. I think I have it. I put an article up, a journal article, and it has pictures of them. So be familiar with where they're located. Um, we have brown recluse, not black widows around here. But there's an article that I added, and it actually shows a picture of it because the only way to really identify it is basically doing a good history with your patient and inquiring about where this happened, what the spider looked like, when the symptoms came on, and then honestly, even sometimes looking at pictures with them to see if you can compare and see if it's actually the same type of a spider, if it's a spider bite. Um, Obviously, check ABCs, look at the skin surrounding that bite or sting to look at the amount of venom that, if you can tell, to see if there's actually like amount of venom that was penetrated in the skin. The other big thing too, you worry about any type of bite, whether it's bug bite or animal, you worry about infection. It's the same thing. So you're looking for any associated infection with it. Evidence of a systemic reaction, you want to look for that. And if you do see this, you immediately treat it as if it's anaphylactic. Obviously, again, I am epi, preferably that lateral thigh, which is the most effective. And you go right through their pants, their jeans, you just immediately give it. Obviously, again, if they show symptoms of anaphylaxis, you have to send them to the ED. In terms of insect bites and stings, same kind of thing in terms of other bites. You want to make sure that you're cleaning out that local wound. And that's big too, because it actually gets rid of some of that venom there too. So washing it thoroughly in soap and water, like warm soap and water. Even mosquito bites, it helps with. If you wash it with warm soap and water, it definitely helps with the after itch essentially there. If you can, obviously, if it's a bee sting, a wasp sting, you want to try to remove that stinger. Um, Ice packs after you clean it. So clean it with warm, soapy water, but then use ice packs because it basically vasoconstricts and then it helps reduce that local vasodilatation that your immune response has in terms of an allergen. Antihistamines, H1 and H2 blockers. So again, H1 and H2 are like things like your Pepcid and diphenhydramine for itching. So if they get hives or they have itching even in general, um, if it's not severe, like not anaphylactic, you can even, because I know obviously diphenhydramine is sedating, so you can always go with like a second generation antihistamine like Claritin, Allegra. Let's say if they had like multiple mosquito bites where they're super itchy and you're trying to get control of the itch, you can put them on like a longer acting antihistamine to kind of help manage that itching as well. The other route that we do too is topical steroids for inflammation. Over the counter is like your hydrocortisone cream is like a 1%. If you want to do something higher, there's different levels of steroids, obviously. Or you can go to like a 2.5% hydrocortisone cream. That generally tends to be somewhat effective for bug bites as well. Obviously, if that's not cutting it too, you can also go to systemic antibiotic, or I'm sorry, systemic uh, uh, steroids, whether it's like a Medrol dose pack. I tend to do a lot of Medrol dose pack because it gives them a quick burst at the beginning and then it tapers them off. Um, you can also go with antibiotics, obviously, too. That's only if signs and symptoms of infection are present. But again, anytime there's a bite, especially with itching, once they start itching it and that itch scratch cycle starts, they introduce bacteria to it so they can get a secondary infection with it. And we'll talk about this as we get into actually this week coming up. We're going to do finish up derm, and it's actually pretty easy. It's more of like the infections that we'll deal with. But a lot of infections with the skin tend to be staph or strep. So in terms of coverage, we'll talk about that this week coming up. But in coverage, we always make sure that we cover staph and strep for generalized skin infections. So if you are suspicious of that, or if they're scratching and then you're concerned about that, then we put them on oral antibiotics. The other thing is NSAIDs. You can also use that too to relieve some of that discomfort, whether it's swelling or generalized pain in the area. That tends to be helpful as well. In terms of tick bites, we'll get to this in a second, but really in general, they need to be embedded for 36 hours for it to actually cause Lyme disease or that infectious process with Lyme disease. Okay, so evaluation and management. So prevention and education is obviously a big thing here, especially with like spider bites, tick, potential tick exposure is a huge thing too. And we actually have it in southeastern Michigan where like deer tick, that's the ones that we're really worried about around here. So it's encouraging your patients to, number one, do a skin check after they come in from outside. Be aware of their surroundings, and if they're out in the woods, that they really should be using repellents with DEET in it. The DEET is what the most effective part of it. I know patients don't like it, but that's really the most effective part of the repellent, essentially. If they do have an allergy, whether it's an allergy to bees, even food, any of that, they really should wear a bracelet with an allergy ID on it. So that way, if for God forbid, something were to happen, they actually have that bracelet on. Making sure they learn how to use their EpiPen, referral to an allergy or an allergist or immunologist. In terms of tick bites, they can transmit different diseases such as Lyme's disease, Rocky Mountain spotted fever, anaplasmosis. So really, you got to take a proper evaluation and management and history on that patient to prevent infection and minimize any complications. So if you were to look it up, and I know I added links for like the CDC website, it depends on the area of where the patient lives, like whether it's the western side of the United States, Midwest, eastern side of the US. That's really determines what type of ticks we have and what kind of disease states they carry or infections or infectious agents they can carry. Because around here it's Lyme disease that we do pose some concern with essentially. But when you do a history, you want to make sure you're looking at like the timing of it, the location of the tick bite, meaning location of like where it happened. Were they on vacation when this happened, or is it here like around our house and our general geographical area? Because you really got to just kind of look up where you practice and determine what the highest risk is in terms of the area. The other thing is you look at duration attachment, because I already mentioned earlier, it usually generally takes like a 36-hour window of time for it to be attached and for a potential transition of infection to the patient. If you can identify the tick species, obviously that's helpful. Sometimes you can actually, you have the patient place it in a bag, or if you remove it, you place it in like a Ziploc bag, because obviously it needs to be sealed, and it can be sent to the health department, or you can call the health department for further assistance, and they can test the tick for the disease, essentially. You do want to inquire about symptoms of infection, so things like fever, rash, fatigue, joint pain. Neuro changes are usually later. But it's something you always think about too. Like if patients present with these generalized symptoms of like fever, joint pain, a rash that they've had ongoing for months or since the summer, and it kind of all of a sudden came out new, it is something to think about. Like think of it back of your mind. Like were they bit by a tick? Did they potentially have Lyme's disease that it was never been diagnosed? Because it can happen. They can get bit, and they're so tiny that some patients don't even know. It falls off before they even knew they were bit. And sometimes they don't have the bullseye rash with it. A lot of patients do, but it doesn't necessarily mean all the time. So always think in the back of your mind if patients present with like almost like autoimmune type symptoms, or like a systemic infection but it's chronic, it's something to think about. Look at their medical history too. Are they immunocompromised? What allergies do they have? Do they have any prior tick-borne illnesses in the past? What do they do for hobbies? Things like that. Are they out and about a lot? Outside? What do they do for a job? Things like that. That's why all these factors, like with your history taking, is critical. With your physical exam, obviously look for the tick and assess whether it's attached or it's already removed. You want to inspect for erythema migrans. That's that bullseye shaped rash, which can be indicative of Lyme's disease. We're going to talk about this more when we get into derm because I'm going to show you some more pictures with it too. But they'll have like that clearing, and it literally looks like a bullseye rash. I'm sure you've probably seen pictures or images of it online. And then all the CDC links I provided too, they'll show you images of it as well. There may be local irritation or signs of secondary infection there too. So that warmth, redness, generalized pain in that or tenderness in that area. And obviously to look for additional ticks in the body. They tend to go in warmer areas like on the body or areas where it's darker. So like look under the axilla, look in the groins. So look in areas that the patient may not really suspect that it may be, because they even get underneath the clothes or they attach on clothes and then attach to the body. So really, you got to do a thorough check on the body, and you really need to educate patients. All patients should be educated on it. If you're outside and you're doing yard work or whatever it may be, they absolutely should be doing a skin check once they come back inside, to make sure that they don't have any ticks attached to them. And then obviously, of course, with the repellents are a critical component too to education. This is just in terms of of removal. You really want to use fine tip tweezers to it. You grasp it as close as you can to the skin, and you really want to pull straight upward. You don't want to twist it, crush it, or pull it sideways because part of the tick can be left in the skin. And then afterwards, obviously, you want to clean that bite with warm soapy water, and then use the antiseptic on the area as well. Even disposal of that tick, you want to make sure you put it in a sealed bag or flush it down the toilet. Um, Other remedies that you've probably heard, like you might hear it online, or patients just kind of generally they hear it from other people, like using heat or petroleum jelly to get rid of the tick or burning it. They might actually irritate the skin more, the tick, and actually could increase pathogen transmission. So there's no evidence behind these other methods of removal, in terms of like using heat. So really, you want to remove it with tweezers, essentially pulling straight upwards. And then you have to do a thorough risk assessment for disease transmission. So how long was that tick attached for? Infection risk increases after that 36 to 48 hours mark. Some regions have higher prevalence of tick-borne diseases. So really, it's good to know what your local area looks like, whether it's like Oakland County, Macomb County, Wayne County. Look all of that up and see where there's high density of ticks. And obviously, too, look at the season. I mean, they can still be present during the winter, but it's less common during the winter than it would be, obviously, in like the summer, fall. But around here, we do have more issues with deer tick, obviously. Um, and then the other ones obviously can be Rocky Mountain spotted fever. In terms of asymptomatic patient management, prophylaxis for Lyme disease. So if it's indicated if all criteria are met. Like if they tick was identified carrying that bacteria, if it was attached for 36 hours, if it's under 72 hours, because you really want to get started early, if they're in a high risk area. And then if you do give prophylaxis, you want to do a single dose of doxycycline, 200 milligrams for adults, or 4.4 milligrams per kilogram for children older than 8. Obviously, too, you got to monitor for signs and symptoms. So you want to make sure that they're watching for fever, rash, flu-like symptoms over the next 30 days. And at that case, obviously, if they're developing symptoms or they get a rash or something new comes on, then you got to treat them symptomatic or systematically in terms of like a symptom based approach. So this is if there's highly suspected or confirmed tick-borne disease. Obviously, with Lyme's, you're going to use Doxy, 100 milligrams twice a day for 10 to 14 days. I always tend to err on the side of caution and do a 14-day regimen. Same exact thing with Rocky Mountain Speed fever. You use doxycycline twice a day, 7 to 10 days. It's the first line in agent in all age groups. Other infections, you really got to tailor your treatment and antibiotic choice to specific disease states. So, if usually in general, like I said, if it's just like a secondary bacterial infection from them scratching or itching, or they have a cellulitis, usually you want to use agents that cover staph and strep. So then we usually go with like cephalosporins, things like that. Doxycycline is still a decent choice too because it covers kind of all of that as well. So you can still go with that. Follow up. So obviously you want to follow up and make sure that they don't have any new symptoms that develop. You always want to inquire about whether they have any issues with fever, chills, joint pain, any neurologic signs or symptoms, or a rash, specifically that bullseye type rash. Did they develop anything like that? You can do serologic testing. If symptoms do suggest tick-borne disease, they're not 100% accurate, but they're definitely useful in clinical practice. You can do antibodies for Lyme's disease via blood work. Before, they used to always have to send them out. Now it's relatively easy to get results back fairly quick. Before you'd have to send them out, it'd take a while. But you can do antibodies for Lyme's disease as well. You can do PCR for other tick-borne pathogens if clinically indicated. So again, prevention, whether it's personal perfection, protection and environmental control, like making sure that their yard is clean and they don't have a lot of leaf clutter around because that's where they tend to be. They tend to be in like tall grasses. So making sure that they're mowing regularly. So those are all areas that you want to make sure your patients know about, and then you educate them as well. Wear long sleeves, tuck pants into socks. In woody grassy areas, make sure that they always check their clothing. In fact, if they're out in the woods a lot, it's good to undress like in their garage before they come in the house because they can actually be attached to the clothing. Um, and you don't want to carry that in, obviously, because they can attach to other things and then reattach to the patient essentially. This is just a question I put on there. It was discuss management of environmental allergens, like what non-pharmacologic interventions can be used, what pharmacologic can be used, and when should you refer. So in general, I mean, go ahead and take a look at this and try to think about your response. You can pause this. But obviously, non-pharmacologic is obviously reduction in exposure. So the big thing, like with pets or like seasonal allergies, is trying to eliminate exposure to it. So like not having pets in the bedrooms or in the bed, changing sheets frequently. If it's outdoor seasonal, like not having your windows open during that time period or season where it's worse for that patient. Obviously, pharmacologic interventions depend on the underlying cause, but things like I already mentioned before, if it's more severe where they're getting hives, then obviously like things like diphenhydramine or Benadryl, a first generation antihistamine. If it's more for seasonal allergies where you're trying to kind of maintain it and prevent them from having allergy symptoms, you can go with like a longer term or a longer acting second generation antihistamine like Allegra, Claritin, Zyrtec, things like that. If they tend to just have like allergic rhinitis, then sometimes going with things like Flonase is good. They don't have systemic side effects with it. And I know we talked about it before too, but even Singular has like a critical role in allergies. Like we use that a lot as an add-on in addition to antihistamines. And then we also use it a lot in allergen-induced asthma as well. Obviously, you need to refer out if you have an IgE mediated reaction. So if they have a anaphylactic type response, they obviously need to be managed by an allergist. Food allergies, I would always send them out because we really got to uncover what they are allergic to essentially. Pulmonologist, obviously, that's involved if they have asthma or shortness of breath and constriction involved with it as well. And you're having like a difficult time controlling that. Okay, so this was for emergent conditions and bites. I want to go through this real quick. This is pretty self-explanatory, but I figured I have this going. I might as well just go through it with you. Let me make it bigger. Just to pull out a few things. I'm not going to read every slide, but Raynaud's, I'm sure you heard of it. There's primary and secondary. So secondary is related to usually typically an autoimmune disorder. So they have an underlying disease state that it's associated with. It can be associated with drugs, trauma, hematologic disorders, vibration exposure. Obviously, frostbite or cold exposure can cause it, or CAD or PAD, essentially. Primary, there's really nothing, there's no identified trigger there, or there's no autoimmune disease that it's related to. So they don't have any autoantibodies present in their serum or anything like that. This is a chart just kind of explaining the difference there. Like when they get it, like the onset tends to be younger with primary, secondary tends to occur older age, and they tend to have more asymmetric symptoms with secondary. So you can go ahead and take a look at that. Clinical presentation, I'm sure you can read this. Obviously, the biggest triggers that you'll see it commonly cause from is cold exposure, rapid changes in temperature, emotional stress, and then even like tobacco use. You'll see that in patients where they get constriction as well. Physical exam, obviously, a lot of times they don't have it actively in the office, so you have to inquire about their history of when they get it, what were they exposed to, how long does it last, have they been having this for days, months, years, etc. Do they have any other autoimmune issues, or does that run in their family? Diagnostics, obviously based on their history, and then really if you're suspicious of like a autoimmune disease, so looking at those other signs and symptoms, you really should do an ANA, which is like a general screening tool for autoimmune disease, and then a possible rheumatologic workup depending on the results of that and the presentation of your patient. So these are just primary management. It's reducing exposure to the environmental cold or keeping them warm, whether it's using gloves, hats, stress management, avoiding smoking and tobacco use. Those are the big things. So it's really honestly, it's more management through what you educate your patient on, like to do. It's rarely indicated, but you can, for primary, you can use like calcium channel blockers like nifedipine for severe symptoms in patients if it becomes more repetitive. Same thing for secondary management. It's really treating those environmental measures like the cold exposure, clothing, stress management, tobacco exposure, etc. But with secondary, again, it's usually related to an underlying condition, most commonly an autoimmune disease or a connective tissue disease. So it's really managing or treating the underlying condition, or even if it's CAD, things like that. So that's what's critical in order to reduce the severity of Raynaud's or even the frequency of Raynaud's, is really treating that underlying issue that they present with. Again, you can use calcium channel blockers like nifedipine, amlodipine. PD4 inhibitors is actually another agent that's used. Antiplatelet therapy or anticoagulants if the patient has like severe ischemia. That's not that common, but those are things that are out there. There's even more invasive treatments like Botox or ganglion blocks. Sometimes that can be done as well. These are obviously for severe cases. These patients, if they have it that severe, they absolutely need to be referred to a rheumatologist and a vascular specialist for sure. In terms of lupus, so again, if you have those patients that present with like chronic fatigue, joint pain, fevers, a malar rash or a butterfly rash, if they have any changes with their skin, you definitely want to look for systemic lupus. So we do blood work on these patients, and generally you do an ANA, like as your initial screening tool, and then you can do like a lupus panel, and I'll show you on the next, I think it's the next slide or two slides down. There is a genetic link there again, and I think I've mentioned this previously. There's like a genetic component there with the genotype, but there's something that really triggers it or triggers it to come on, and that's usually typically something environmental, whether it's a recent illness, a trauma, significant infection, and there's something that environmentally triggers it to come on. Essentially, that genetic link is essentially um, is becomes present in the patient, and they have symptoms of it essentially. It's a chronic autoimmune disease. It's characterized by inflammation and damage to various tissues and organs. So it's a systemic disease. Just remember that it can have a multitude of symptoms based on the systems that it impacts. Essentially, it's very individualized, and the severity and organs involved are obviously very individualized as well. So general principles of treatment is tailored to disease severity, organ involvement, and patient factors. So it's really dependent on the patient, like their age. Do they have comorbid conditions like CAD, asthma, things like that? Do they have chronic kidney disease? It's really preventing severe progression of the disease and also preventing organ damage from the disease. And really, the goal is to try to get them into and to get them into and maintain remission. This is the general presentation. You can go ahead and read that. So you can see that it does have a systemic response. Physical exam, you really got to do a thorough exam, everything from GI, pulmonary to the skin. So you're looking for like that malar butterfly rash, or they could have a more spread out discoid lupus type rash as well. These are the diagnostic tools that I mentioned. In terms of blood work, you can do a SED rate and a C-reactive protein, and those aren't specific for lupus, but it does give you a good idea of like how active the disease is, and it's a good inflammatory marker, or markers, I should say. And then you always start with an ANA, and you always want to do an RA to make sure that they don't have rheumatoid arthritis as well. Then there's the lupus panel. So lupus panel will have like the anti-Smith antibodies, the anti-double-stranded antibodies. So if their ANA comes back positive, usually it'll come back with a pattern. And usually the lab will tend to say like, oh, it's this pattern, like speckled pattern, or heterozygous speckled, and then recommend SLE panel, or recommend checking for RA. So usually you'll get some kind of feedback from the lab depending on the pattern of the ANA. And then you can add it on as a reflex panel essentially with the patient. You do want to get a BUN and creatinine, a CBC with DIF, because you can get lupus nephritis. They also are at risk for anemia as well. And obviously you want to make sure that they don't have any signs and symptoms of infection as well. 24-hour protein is also done typically too, because obviously the association with nephritis, and they start to excrete protein in the urine. So if you remember, if we talked about protein, when you start spilling protein in the urine, it's usually related to chronic kidney disease or detriment to the kidney essentially. Meds, it's always good to recommend like an omega-3 fatty acid or a fish oil supplement. Steroids are often used, but they're used, you really want to use steroids cautiously. When you're using it for any disorder, and especially with rheumatologic disorders, because obviously it's a chronic thing and you don't want to keep them on steroids forever. So you really want to go with the lowest effective dose and then taper them off of it if possible. There's some patients that don't tolerate it though, and they do require being on prednisone, like a real low dose of it. But remember with steroids or prednisone, there's a lot of systemic side effects for like whether it's weight loss or like a Cushing type syndrome presentation as a side effect. Blood sugar, they're at heightened risk obviously for diabetes, they're at heightened risk for infections. It can cause mood imbalance. So there's a lot of things, weight gain, things like that. So obviously that's why you don't want to keep them on it long term, and you want to keep them on that lowest effective dose. Also being aggressive with managing any other chronic diseases or prevention. So obviously things like statin management. You want to be more aggressive with their statins to prevent CAD. Low dose aspirin for high risk patients. NSAIDs, obviously, too, for joint pain and an inflammatory response in the body as well. The first treatment line or choice essentially is an anti-malarial, and it's Plaquenil. That's usually the first line treatment in patients unless it's contraindicated. Other things like methotrexate are definitely used a lot too, or monoclonal antibodies. With any of these meds, though, you really want to make sure, especially these other ones that suppress the immune response, that they're getting regular physical exams, gynecologic exams, that they're getting screening done, whether, it's their pap smears, mammograms, colonoscopies, those cancer prevention screens, and then making sure that they're also up to date with influenza vaccine status or their general vaccine status, essentially, because you want to make sure that you're preventing infection. So it's preventing the progression of comorbid disease states or chronic disease state development. Any patient that has lupus, you do want to ensure that they are referred to a rheumatologist as well. This is just a table. I added it. It gives you a table of like the epidemiology in terms of blood work that you can do. The big thing, like I mentioned just a second ago, is evolution of chronic disease. You really got to watch their kidneys, be aggressive with their lipids because of this, and hypertension management and things like that. This is a really great table to look at, and I added the article on it. And there's another good article on doing, I think it's on lab. I think it's got a huge section on lab values for rheumatologic disease states. But these are things from like the primary care perspective that you really got to keep tabs on in terms of your patient that has underlying rheumatologic disorder, especially lupus. And if you look at it, it'll talk about things like cardiovascular abnormalities, like making sure you're aggressive with the lipids, their blood pressure, other things with their kidneys, like making sure that you're checking to make sure they don't have protein in the urine, BUN and creatinine. If they're on steroids, obviously being on top of things like their weight, their immune system, so vaccine status, and doing what other ones? Diabetes status too. That's the other one I want to mention too. So go ahead and take a look at this, but these are good things to recall, like from a primary care perspective, in terms of what your role is in terms of managing that patient with these chronic rheumatic disease states, essentially. So go ahead and take a look at that because I feel like it gives you a good idea as to what your role is as a PCP for that patient. These are just different other areas like patient education, lifestyle modifications. Sun protection is a big one because they definitely have photosensitivity just from the underlying disease state, but also from medication use as well. An anti-inflammatory diet is also helpful, like omega-3 fatty acids, lots of fruits and veggies, lots of fluids, like not necessarily things with caffeine, but like lots of water, and then calcium and vitamin D intake as well. Psychosocial sports is also critical too. So making sure that they're coping with chronic disease management or new onset diagnosis of systemic lupus. Because obviously it's a lot to manage for the patient in terms of starting new medications and then the thought that they have this lifelong and that they have to manage it obviously can be taxing on the patient and their family as well. Okay, so I just wanted to go through that. I know I went through this one pretty quick, but I figure it's pretty straightforward. And so I'll just have you take a look at it, and then I know I have to get caught up with the lecture on derm, and then let me stop sharing, and then I'll get that posted for you guys to as well. And then I know we have class coming up, so we'll do case studies in class and go through to kind of reiterate or rehash some of this material as well. Obviously, if you have questions, just reach out to me. I'm more than happy to help, or I will see you guys in class. I hope you're all doing well. You're almost there with the semester, so hang in there. I will talk to you all soon. Thank you and have a great day.